Welcome to The Explainer. Today, we're exploring the absolutely fascinating yet incredibly fragile world of the inner ear. We're going to look closely at how unseen viral invaders can literally steal our hearing in an instant. It's a journey straight into a microscopic battlefield, and honestly, understanding it might just save your senses one day. So, think about this for a second. Do you actually know the difference between standard, gradual age-related hearing loss and a sudden, silent viral attack on your ear? Most of us just expect our hearing to naturally kind of fade as the decades pass. But what if you woke up tomorrow and the world was just completely quiet? That sudden drop? That isn't aging. It's an ambush. And knowing the difference is an absolute medical emergency. Okay, let's take a quick look at our agenda for today. We'll cover 1. What is sensory neural hearing loss? 2. How viruses damage our hearing. 3. Congenital CMV in newborns. 4. Our clinical review on diagnosing the loss. And 5. A patient guide for treatments and devices. All right, diving right in with section 1, what is sensory neural hearing loss? Let's define the condition. So, sensory neural hearing loss, we'll just call it SNHL, is definitely not your standard earache. Unlike a temporary blockage, maybe caused by earwax or fluid, this condition involves the permanent destruction of the tiny, delicate hair cells inside your inner ear, or even damage to the vestibulocochlear nerve itself. Sound waves might still enter the ear just fine, but the broken biological machinery just cannot convert those waves into the electrical signals your brain interprets as sound. And here's the kicker. Once these specific hair cells are destroyed, they cannot repair themselves. They're gone. Moving right along to section 2. How viruses damage our hearing. The fortress under siege. There is a really striking quote from our sources that says, the human cochleovestibular system is a highly specialized anatomical microenvironment, highly vulnerable to pathological insults. Basically, what makes the inner ear so awe-inspiring is exactly what makes it so incredibly fragile. It relies on a terminal vascular supply. That means there's zero backup blood flow if the main line gets blocked. Combine that with its super delicate fluid dynamics, and well, when a virus breaches this protected space, it's a total disaster. So how exactly do viruses pull this off? Well, there are 3 main ways they execute this damage. First up is direct cytopathic damage. This is where viruses like the mumps virus physically invade and just destroy those sensory hair cells. Second is a localized cytokine storm. Here, the virus triggers a massive inflammatory cascade that causes the cells to essentially self-destruct. And third, we have microvascular dysfunction. This causes acute localized ischemia, which is a fancy way of saying the virus cuts off the blood and oxygen supply to the ear. Now, here's a really interesting, albeit scary, example. SARS-CoV-2, the virus that causes COVID-19, actually operates by using ACE2 receptors to enter the neurological system. In the inner ear, it creates a hypercoagulable state. That means it triggers your blood to clot way too easily. This leads to microscopic blood clots right inside the labyrinthine artery. And remember how we said that artery has no backup circulation? Yeah, those microclots instantly starve the cochlea of oxygen, causing sudden and permanent hearing loss. Okay, section 3, congenital CMV in newborns. Protecting the most vulnerable. We absolutely have to talk about congenital human cytomegalovirus, or CCMV. It is the absolute most common non-genetic cause of SNHL in newborns. It's totally a silent invader. While a baby is still developing in the womb, the virus can invade the inner ear from the bloodstream, causing microcirculation disorders and cellular damage. Because babies obviously can't just tell us their hearing is fading, early and really aggressive detection is absolutely vital so they don't miss crucial developmental milestones. And when we say early, we mean a super strict 30-day intervention timeline. The Valgan-Ciclover protocol means clinicians have to work fast. Right at birth, they first have to exclude other genetic causes. Then, within the very first 21 days of life, they need to confirm the CCMV diagnosis using a saliva or urine PCR test. If that comes back positive, they have a really tight window, specifically before the baby reaches 30 days old, to initiate Valgan-Ciclover antiviral therapy. Hitting this exact window can significantly improve the newborn's hearing and overall developmental outcomes. Moving into section 4, our clinical review. Diagnosing the loss, and yes, this is a medical emergency. 30 decibels. That right there is the magic number. It's the diagnostic threshold. According to clinical guidelines, for a patient to actually be diagnosed with sudden sensory neural hearing loss, they have to experience a minimum 30 decibel decrease in their hearing. It has to affect at least 3 consecutive frequencies, And the whole thing has to happen within a 72-hour window. If your hearing drops by that much, that fast, the clock is literally ticking. But hold on, before anyone hits the panic button, doctors first have to differentiate between SNHL and conductive hearing loss, or CHL. SNHL is that inner ear nerve damage we've been talking about, the one requiring immediate medical intervention. CHL, on the other hand, is just a physical blockage. Think impacted earwax, a foreign body, or maybe just fluid from an ear infection. Figuring out the difference between these two using basic tuning fork tests, specifically the Weber and Rinne tests, is the absolute most critical first step for any clinician. So let's see how this all builds into the rigorous 4-step clinical guideline pathway published by the American Academy of Otolaryngology. Step 1, differentiate the type of loss, like we just talked about. Step 2, confirm the diagnosis via audiometry as soon as possible, but definitely within 14 days. Step 3, evaluate for any underlying systemic causes, like metabolic disorders. And finally, Step 4, order targeted retrocochlear imaging, basically an MRI. Now, why an MRI for Step 4? Well, clinicians absolutely must rule out serious underlying tumors. For example, a vestibular schwannoma, which is a non-cancerous tumor on the main nerve leading from your inner ear to your brain, is actually identified in about 3.5% of patients who present with sudden hearing loss. You know, in medicine, knowing what not to do is honestly just as important. The clinical guidelines strongly recommend against ordering routine head CT scans. Why? Because CT scans are just highly insensitive to inner ear pathology. They simply won't show the microdamage we're looking for. Furthermore, clinicians really shouldn't obtain routine, undirected laboratory blood work. These tests just waste precious time, and they don't predict patient outcomes or change the immediate treatment plan. Bringing us to our final section, Section 5. Patient Guide, Treatments, and Devices. Restoring the connection. When it comes to treating sudden hearing loss, there's a saying, time is tissue. These specific intervention windows totally dictate the medical response. Within the first 2 weeks, the primary attack is high-dose systemic corticosteroids to violently suppress that inflammatory cascade. If things haven't fully recovered between weeks 2 and 6, doctors move to what's called salvage therapy, which is actually injecting steroids directly through the eardrum right into the middle ear. Concurrently, within the first month, hyperbaric oxygen therapy can be used to reverse local hypoxia by literally forcing high-tension oxygen into those highly metabolic cochlear structures. Ultimately, our targeted treatment protocols depend entirely on the exact nature of the loss. Idiopathic cases get the high-dose steroids. Newborns with congenital CMV get the Valgan cyclovir antivirals. But if those therapeutic windows are missed, or the viral damage is just too catastrophic, we have to look to devices. For permanent loss, hearing aids can amplify sound, and cochlear implants can physically bypass the dead inner ear entirely, creating a brand new electrical pathway straight to the brain. It's pretty incredible stuff. We've covered a tremendous amount of ground today, from microscopic viral mechanisms all the way to strict 72-hour clinical windows. So I want to leave you with this final thought. The architecture of our senses is beautiful, but it's incredibly fragile. If your hearing vanished in a matter of hours, would you know exactly what to do to save it? Well, now, hopefully you do. Thank you so much for joining me on this explainer. Keep learning and stay curious.